So as you all heard already, docetaxel is the standard chemotherapy in metastatic prostate cancer. If we started with first line or later on, it's still the chemotherapy we are giving in the setting of metastatic prostate cancer. And this docetaxel, all the taxanes have side effects, and we divide them into hematological and non-hematological side effects. And the most common side effects, it means something about 30%, are in non-hematological, like fluid retention. It is when you start gaining weight, or your swelling of your ankles, or also your abdominal area, but also some dyspnea. Then we have the gastrointestinal problems like nausea, vomiting, and diarrhea under chemotherapy. The oral mucositis, I will come on back to this. Hair loss, I think that's a big issue, not only for women. Fatigue, like all of our patients, all of our cancer patients in general have it, and prostate cancer patients during chemotherapy especially. Nail changes, can go to nail changes of the color and also the substance of the nail. But a very important one is, I think, it's peripheral neuropathy, which I come on later. This is how your chemo looks like. So usually docetaxel is admitted on day 1, and there is a 21, so it's a 3-week schedule. And there is a so-called nadir, where medical oncologist or your doctor should be aware of. This nadir means the low point. This is the point between the 2 cycles where your blood counts has the lowest rate. So also your red, your platelets, but also your white blood counts. And these hematological side effects, like leukopenia, it means the lowest low number of white blood cells, is associated with an increased risk of infections. And what we all are afraid of, so the medical oncologists, is the so-called febrile neutropenia, where you have fever and no kind of immune system, no cells avoiding the bacterial infections. And this can really lead to septical status and also to death. Then we have thrombopenia, where you start bleeding. There are some good signs if you're at home and you don't know if you have thrombopenia or not. If you start bleeding out of your mouth when you brush your teeth, or you have little red dots on your skin, that's a sign that you have low platelets. It's lower than 30. And anemia, as we all know, in all cancer patients, fatigue is associated also with anemia, but also shortness of breath is associated with it. What we can do against it. My topic is also prevention. What the oncologists do when they start with the chemotherapy, there are some risk factors. If you will develop a kind of neutropenia, so the leukopenia, and after you gave you the chemotherapy, they can give you some growth factors that help rise the white blood counts. And this is what we do. Sometimes we give it regularly, just when we start to give it. Sometimes we give it only in cases the patients had already some risk factors for that. The next point, and I think this is one of the most important ones, is the so-called chemotherapy-induced peripheral neuropathy. It is quite common with taxanes, and we can differentiate in an acute and a delayed form. That means right after the chemo and months later after you have finished chemo. And this means it's a systemic, length-dependent distribution of numbness in your fingers and toes. It feels like you have gloves or stockings on. It occurs with repeated doses. It worsens with progressive doses. So it worsens when we don't reduce the dose of your chemotherapy. And it's mostly reversible, but we have seen patients who cannot button up their shirts anymore. I've seen patients who cannot walk anymore, and this is not our goal with our chemotherapy. So we should be aware of and talk to our patients about how important this is to watch out for the signs developing peripheral neuropathy. Prevention of peripheral neuropathy would be great, but we don't have anything against it. We had a lot of clinical trials going on with antidepressant, anticonvulsants, from vitamins, but to date, there is not one single trial that's shown a meaningful clinical benefit when compared to placebos. So the management is what we can do. And what I told you in the beginning, it's dose reduction what we can do. And there is only one drug really highlighted in the guidelines with a level A evidence, so it's a huge evidence. It's called duloxetine. It's an antidepressant. In Austria, the name is Cymbalta. I'm sure some of you are aware of it. But there are no clear recommendations for other drugs. But we still give gabapentin and pregabalin if our patients have pain accused by peripheral neuropathy. It's called Neurontin or Lyrica, or also tropical treatments like lidocaine-containing gels or morphine-containing gels or ketamine. And there are some non-pharmacologic interventions like acupuncture, e.g. But I think what's really important is that you talk to your doctor. As soon as you start feeling some paresthesia, numbness, anything in your part of your body, you should talk to your doctor, then he can start acting against it. Mucositis is the next one. Mucositis can develop is a mucosal damage, but it can develop in your oral cavity. It can go to your pharynx, larynx, esophagus, and all the other areas of your gastrointestinal tract. The symptoms of your oral mucositis can be painful erythema and ulceration, and you cannot eat and drink anymore. That means impair of nutritional intake. And GI mucositis is starting with nausea, vomiting, diarrhea, and again, impair of nutritional intake. And this is also a big problem in life quality when you get chemotherapy. So prevention and management of mucositis, oral mucositis, very important, or basic oral care. That means brushing your teeth, using a floss, and doing some mouthwash. It is not written in the guidelines that you have to use this mouthwash 4 times a day, but it's still good. Then when it starts, we can have some anti-inflammatory agents, and then the painkillers, systemical or topical. There are some mouthwash with lidocaine or morphines. And then we have systemical morphines. And believe me, some of our patients really need it. I mean, and hydration and parenteral nutrition in really severe cases, like you see on this side. Okay. GI mucositis, we have antiemetic therapy, but what we should do, prevention is really important in antiemetic therapy. We should not see our patients start even with nausea and vomiting. Otherwise, there is a much harder to fight against it. Then we have loperamide, it's Imodium and Terobene in Austria. Against the diarrhea, octreotide, if loperamide is not enough. And then again, hydration and parenteral nutrition in severe cases. There is another trial showing us that maybe the change in your dosage, in your schedule, in your chemotherapy schedule might help prevent these toxicities. It's 2 versus 3 weekly docetaxel, which was published 2014. And it's 2 weekly docetaxel and 3 weekly docetaxel. You can see it on the curve. There is no difference in time to treatment failure, and there is no difference in overall survival, but you could reduce the toxicities in a significant way. And I think this is something that our doctors, your doctors, should be also aware of. Bisphosphonate and denosumab. Some of you might know, these are anti-resorptive agents that helps you to avoid bone loss in androgen deprivation therapy, but to avoid also skeletal-related events due to bone metastasis. And also, it is prescribed when you have a hypercalcemia due to bone metastasis, which occurs quite common in highly metastatic prostate cancer. Serious events are, I think there are some lighter serious events like rhinotoxicity, then we can do something against it. But the main problem is the so-called medication-related osteonecrosis of the jaw. It is a bone destruction of the maxillofacial region where your teeth are. The pathophysiology is still not clear. Some say it's inflammation, some say it's an infection, microtrauma, or altered bone remodeling. But what we know already, that we have some risk factors. This is a way of administration, so orally or IV. Underlying disease, I see some patients with multiple myeloma with some high incidence of this ONJ. Oral surgery, therapy length, how long you got your bisphosphonate or denosumab, the age, obesity, and concomitant diseases. Prevention, very important. Basic oral care is again very important. And what your doctor should watch out before starting this therapy is that you should see your dentist and treat your teeth before the starting of this therapy, if it's possible. Management. It should be not just managed by your dentist. It should be managed by your medical oncologist or urologist and the maxillofacial surgeon. Treatment is either conservative or surgical. It's a case-by-case decision. It depends on how bad it is. And the goals are control of pain and infection and also control of bone necrosis. Then we have so many other therapies. It's cortisone, all the hormonal therapies, and also the neural hormonal therapies. I think I don't have the time to go into them in detail, but we have the bone loss, the hyperglycemia, in therapies with cortisone, cardiovascular problems with all over the ADTs, constipation, diarrhea, all the hot flush, erectile dysfunction, loss of muscle mass, depression, and then we have arthralgia, which is also very bad in your ADT therapy. Prevention and management, there are so many topics that I cannot go into detail at this, but it's important you just stay in your life, just try to exercise, substitution of calcium and bisphosphonates to avoid bone loss, and regular controls of your laboratory levels and to treat your cardiovascular risk factors, like your cholesterol and also your hypertension. And maybe also some change of the substances. Enzalutamide can be given without corticosteroid, and maybe enzalutamide instead of abiraterone, if it's feasible for you, would be another option. Just one more trial I want to show you, because it was just presented a week ago at ASCO meeting. This was the American Society for Clinical Oncology. And what they did is they looked at their patients and how they are, if they have a benefit, if they have more control about their symptoms during their therapy. So what's happening in our place? And now it would be good to have a microphone. What we do is our patients, like you, are at home. And they go to the hospital and they don't have time, doctors have no time, and you cannot discuss all of your problems with the doctors. They forget to discuss because there are many issues. And then the patients at home, they try to avoid the contact to your doctors. And then if they want to try to contact their doctors, they cannot get through to them. So what they did is they tried to make an alternative symptom monitoring. So they sent their patients e-reminder, and by iPads and emails, and there were questions, and these patients, and if one of the questions were highlighted by the patient and the symptoms were severe, even the doctors and the nurses get an alert mail. This is the study design. They ask for the most common symptoms in different metastatic cancers, and they got weekly reminders and then the alerts I just mentioned. The outcomes were life quality, ER visits, and benefit in survival. The first outcome, quality of life, you can see it's a significant gain in quality of life by having this control by your system. And then we have the secondary outcomes, like ER visits, 7% fewer patients in the emergency rooms, only by some emails and disease control by electronic data, and also the survival, and I think this is the most amazing point. There was a gain of 5 months overall survival in these patients who were monitored regularly and not just in case by case during the course controls in their hospitals. So summary of my talk is we have rising numbers of therapies and we have rising numbers of toxicities. Prevention is mostly important, but the more important is communication. Inform your doctor, and if you realize any changes during therapy. And I believe that the future is systemic symptom monitoring with patient self-reporting systems. Thank you for your attention.